Understanding borderline personality disorder, BPD, is especially important for direct care staff working with people who have developmental disabilities. While not every person with developmental disabilities has a co-occurring mental health diagnosis, BPD can appear in some individuals, making caregiving more complex and emotionally demanding. BPD is frequently misunderstood, and the stigma surrounding it often prevents people from receiving the compassion and structured support they need. This presentation will unpack the key features of BPD, what it looks like on the outside, how it feels on the inside, how it develops, and how it can be treated, to help care staff offer more informed and empathetic support. One of the biggest barriers to understanding BPD is the confusion around its label. Because it's called a personality disorder, some people assume it's a permanent flaw or an unchangeable part of someone's identity. This misperception contributes to stigma and makes it harder for those affected to get help. People with BPD are often wrongly labeled as difficult, manipulative, or dramatic, particularly when their emotional responses or behaviors seem unpredictable. These harsh stereotypes not only fail to capture the true experience of the disorder, but also harm the individual's self-worth and relationships with others, especially those in caregiving roles. Borderline personality disorder is marked by three central features: unstable relationships, intense emotions, and a fragmented sense of self. These symptoms often arise from a deep fear of abandonment and an inability to regulate emotions in a typical way. As a result, people with BPD might react strongly to events others find minor or ordinary. They may have trouble maintaining a steady sense of who they are, and their behaviors may swing between extremes, loving someone intensely one day and withdrawing the next. Understanding these patterns as symptoms rather than personal failings is essential to providing compassionate care. In their daily interactions, individuals with BPD may form relationships quickly and deeply, sometimes leading to unrealistic expectations. They may idealize a new friend, romantic partner, or caregiver, only to suddenly feel betrayed or abandoned over a small disagreement. This push-pull dynamic can create a cycle of closeness and conflict that confuses others. For direct care staff, it's important to recognize that this behavior doesn't come from a place of manipulation. It's rooted in fear and vulnerability. Even routine changes, like a shift change or missed appointment, can trigger intense reactions when interpreted as signs of abandonment. Emotions are often felt with overwhelming intensity by people with BPD. A forgotten birthday, a change in tone of voice, or even a neutral facial expression might trigger what appears to be an outsized response: anger, tears, or withdrawal. To the individual with BPD, these events aren't small. They feel like confirmations of their deepest fear, that they are unworthy of love or doomed to be left behind. These reactions can wear on support staff, but understanding them as manifestations of inner turmoil rather than willful behavior can help staff remain patient and supportive. A lack of stable identity is another common trait in BPD. People may change their hobbies, clothing style, or even values and beliefs, depending on whom they're with. They may say things like, "I don't know who I am unless I'm with someone." This deep confusion about one's identity creates a vulnerability where others' opinions and actions heavily influence their sense of self. For caregivers, this can mean offering steady reassurance and helping the person discover and affirm their personal values, preferences, and interests in a calm, non-judgmental way. The internal experience of someone with BPD is often dominated by the fear of abandonment. Even brief separations, like a late return from a staff lunch break, can be interpreted as a signal of rejection. This fear can lead to frantic attempts to avoid being left alone, including clinginess, anger, or efforts to keep someone close by any means. For support staff, setting consistent boundaries and explaining them with kindness and predictability can help reduce anxiety and build trust over time. People with BPD also experience emotional pain on a scale that might be hard to grasp from the outside. Something like a disagreement with a friend can spiral into feelings of devastation or hopelessness. This emotional pain can persist for hours or days, leaving the individual exhausted and disoriented. Over time, even their support systems, friends, family, or staff, may begin to pull away, making them feel even more alone. This reinforces their fears and can make them even more reactive, creating a painful cycle. Feelings of emptiness are commonly described by individuals with BPD. They may say they feel hollow inside or disconnected from the world. This emptiness can lead them to seek out stimulation or companionship in intense and sometimes unhealthy ways. They might act impulsively, not because they want to cause harm, but because they're desperately trying to fill a void. Being a steady, non-judgmental presence in their lives can provide an anchor during these times of emotional disconnection. Dissociation, or feeling detached from oneself or reality, is another coping mechanism often seen in BPD. In moments of extreme stress, individuals may feel as if they are observing themselves from the outside, or that the world around them isn't real. This can be alarming both for the individual and for staff. Rather than panic, caregivers should calmly ground the individual with sensory cues, like describing the room or offering something cold to drink, while gently guiding them back to the present moment. Behaviorally, impulsivity is common, whether it's risky sex, reckless driving, substance use, or binge eating. These behaviors often emerge from an urgent need to escape emotional distress. They may not fully understand why they did something until afterward, and this can lead to feelings of guilt and shame. Supporting individuals in developing alternative coping strategies, like physical activity, art, or mindfulness, can help reduce the need for impulsive escapes. Self-harm is another behavior associated with BPD. This can be deeply distressing to witness, especially for those unfamiliar with the condition. Self-harm may serve as a temporary release or a way to express emotional pain that words can't capture. It's important to understand that while it may resemble suicidal behavior, it is not always a suicide attempt. Responding with calmness rather than fear or judgment helps keep communication open and allows for appropriate support to be given. Sometimes, individuals with BPD act in ways that seem manipulative, such as threatening to hurt themselves if someone leaves. While these actions can place caregivers in difficult positions, it's crucial to understand the underlying motivation. They are not trying to control others so much as they are terrified of losing someone or being alone. Validating their emotional pain while maintaining healthy boundaries is one of the most challenging but essential parts of working with someone who has BPD. As for why BPD develops, research points to both genetics and environment. There's evidence that some people are biologically wired to feel emotions more intensely, which sets the stage for difficulties in emotional regulation. However, these traits alone don't guarantee BPD will develop. The environment plays a huge role, especially childhood experiences. When a child's emotions are dismissed, punished, or ignored in early life, they may grow up without learning how to process or trust their feelings. Trauma, neglect, or inconsistent caregiving can further reinforce these patterns, creating the foundation for BPD traits. Despite its challenges, BPD is treatable, and many people improve dramatically with time and the right support. Dialectical behavioral therapy, DBT, has been especially effective for treating BPD. DBT teaches skills in emotional regulation, distress tolerance, interpersonal effectiveness, and mindfulness. These tools help individuals slow down their reactions, recognize harmful patterns, and build healthier relationships. With commitment and support, many people with BPD move toward more stable and fulfilling lives. In conclusion, borderline personality disorder is not a life sentence. It's a complex and often misunderstood condition, but one that can be managed and even significantly improved with time, therapy, and consistent support. For direct care staff, understanding the symptoms and experiences of BPD helps create a more compassionate, stable environment where healing can occur. As caregivers, your presence, patience, and knowledge can make a tremendous difference in someone's journey towards self-acceptance and emotional well-being.